Thank you, Congressman. And I'm also going to invite the panelists, if they want to comment further, to raise their hand and I'll go on. Yes.
Let me say a couple of things. One is that it's probably not going to happen this year, but I think the federal government needs to look at bulk buying of pharmaceuticals for all of its plans, for all of it, whether it's Medicare, the VA, et cetera, so that it does tend to drive pharmaceutical costs down. I think one element of the bill, however, that is important is setting up an institute that looks at practice parameters, that looks at which process, which way of taking care of a particular disease, which medication works best. Most people believe that we practice medicine because we know what the outcomes are going to be and what the best process is. That's not always the case. As a matter of fact, that may be in a minority of cases. That a lot of what we do is not necessarily based on good science. And if we have a national institute that looks at results-oriented methods of treating disease, and that should include which drugs work best and work cheaper, then I think that that's going to, in the long run, save us a good deal of money.
To add to that, as all of you may or may not know, 65% of the time, drugs only work 65% of the time the way they're intended to for people. And in addition to that, most of the newer drugs are just knockoffs of the older drugs. They're just trying to get a newer patent, and so they can extend their profits. So it's really important for in that respect for the government to have some leverage, because if you just left this all up to the private marketplace, people would be paying essentially taxes. You know, they talk about how government taxes. What about the private sector gouging you on all these incredible inflationary prices on drugs that are unnecessary because the drug is not nearly different than the one that you paid, that you had before. It's just that they've spun it differently and given it a new name. And these are kinds of things that this comparative effectiveness research institute would be able to clear up and bring more transparency through. So when you got prescribed a drug, you knew that it was the kind of drug that would be effective for you. Thank you.
Thank you, Congressman. Donna?
I was having a conversation yesterday with a group of colleagues, and one of the suggestions that came up to reduce costs was to eliminate, and I'm sure we have to do this through legislation, eliminate direct marketing to consumers from pharmaceutical companies. Because that cost is built into the price of those drugs. So, you know, I don't know about you, but I'm getting tired of seeing Cialis commercials in the 2 bathtubs. And, come on, we get it, right? So, I mean, they can certainly direct market to providers, but to constantly be direct marketing to the consumer, you are paying for that. So that might be something we could.
But can I also address that? Because, and by the way, I can't understand the 2 bathtubs. In the Medical Society, we actually looked at direct-to-consumer advertising a few years ago, and I'm really glad to see, at least judging from the clapping, that it may actually have some opposition here. But it does have a good deal of support among the public, and that is problematic, because if you do some polling, you will find that up to 20% of the public whose doctor refuses to give them the drug that they saw on TV are willing to go to another doctor.
I should also, Nick might comment on this, but even in direct marketing to doctors, drug companies often don't give the full experience in all of their testing. We found this with a lot of drugs where they show, obviously, the positive, desired tests that show that the drug worked in these instances, but they don't show the full, all of the tests that they had in the past. So we need to, and this is where government is more responsive to the consumer, because we can require them to show the full, all of their tests that may not be so beneficial to the drug company to reveal from their financial point of view.
Thank you, Congressman. You know, I have so many questions here that clearly this is a worthwhile enterprise, and I wish we didn't have time constraints. I'm going to try to roll some of them together, so bear with me. I'm trying to paraphrase. I'm going to do one more from the cards, and then I'm going to take one from the floor and then go back to the cards, which will give me a chance to roll some more together, I hope. This one deals with workforce issues. It seems to be hard to get appointments with doctors, and nurses are in short supply. Where are the healthcare workers going to come from? And growing the supply of nurses is key to expanding service, plus paraprofessionals in the field need a career ladder to become RNs, and then the ability to pay the cost of advanced practice. I think I've got the sense of that one, and I think, Congressman, although you're welcome to comment, you can take a breath and we'll direct it to the doctor and the nurse.
Well, as we've all heard for many years now, we have a nursing shortage. The economy burst that bubble this past year because many nurses who had planned on retiring, many nurses who were working per diem or part-time had to go to full-time because their partner, spouse, or their economic situation precluded them from continuing to work part-time. Their 401k became a 201k. They could not retire. For example, I was at my 40th reunion last night at my nursing school. We were the youngest class, and there were nurses there in their 70s, mid-70s, who are still working, who are still in the profession because they financially have to work. But let me warn you that this bubble is going to burst, and you're going to see the true, real nursing shortage. And we know through studies, such as the SHAPE study and other studies that we've done, that by 2025 in this state, we are going to be lacking thousands of nurses to take care of you. And we know that with healthcare reform, that nursing care is going to be preeminent in reform. So the other thing we know from our Senate Study Commission that we had this year is that we have a severe faculty shortage. We can't bring students into nursing programs if we don't have the faculty to teach them, both in the nursing curriculums and the other curriculums, hard sciences, chemistry, math. If we don't have those faculty in place, how can we accept students? Also, the public thinks, I think, that nursing curriculum is a slam dunk. It's hard. It's a very difficult curriculum. You know, organic chemistry, physics, pharmacology, a lot of hard sciences. So many of our young people go in thinking that they're going to come up with a wonderful job, and after spending 1 or 2 years in college realize that they can't make it through. So we have to start earlier. We have to start at the high school setting, getting our students, the nurses of the future, ready in math, science, writing skills, in order for them to succeed and become the nurses of the future. We have to raise nursing faculty salaries. How we do it, I don't know, but we need to do it. If not, nursing schools are going to shut their doors. And we have nursing faculty here, and the Dean of Rhode Island College here, so I'm sure they can attest to that. The average nurse who works at the bedside can make $80,000 to $100,000 a year. The average faculty member who is master's prepared or higher makes $45,000 to $65,000 a year. There's such a disparity in this that we have got to close that gap sooner rather than later. Advanced practice nurses are going to be the foot soldiers of primary care if healthcare reform comes in. We have less primary care doctors in the state, I believe now, than we have nurse practitioners. Who's going to deliver primary care? It's going to be a team approach. It's going to be nurse practitioners and physicians and other healthcare providers who are going to come together and form these medical homes.